Yeah.
Dear friends, Foxians and women of my country, I am Dr. Shanta Kumari, President of the Federation of Obstetrics and Gynecological Societies of India. As a little girl, I told myself that I have to become something to make a difference. I always believed that if I desired something wholeheartedly, there is a positive force which makes it happen. And here I am, friends, standing in front of you as the 60th President of Foxy, the 38,000 strong committed body of OB-GYNs taking care of women's health in our country. As a young girl, I realized that women play a key role in this world, just like Mother Nature or Stree Shakti as we revere it. It is a guiding force behind all forms of God's creation. And it's only a woman who can actually create a new life.
Hi, I'm Kareena Kapoor Khan and I'm so happy to be here with you, if only on video. Pregnancy is a beautiful experience and I have loved having my babies. I congratulate Dr. Shanta Kumari as taking over the 60th president of this eminent organization.
Stree Shakti is the embodiment of 5 elements: the sky, the air, the water, the earth, and the fire. Any imbalance in any of these 5 elements creates chaos and calamities. Similarly, when a woman's health is neglected, it disrupts the universal equilibrium. The intimate link between environment and human well-being is very well known. With increasing awareness of the need for clean water, pollution-free air, and pesticide-free food.
Hi, I'm PV Sindhu. Well, it's such a beautiful feeling for me to be an empowered girl, to be a girl in a nurtured and a safe environment.
Protecting health by preserving nature and its ecosystem is easier than curing any disease. So we have taken up the concept of minimizing the female morbidity and mortality and fetal effects by mitigating the adverse impact of environment. My theme this year goes beyond Foxy's commitment towards women's healthcare. Foxy for all, always.
Foxy for All is another inspiring campaign. What you do in this organization impacts the lives of all of us women in India.
And Dhira to stop violence against women. Foxy for all, always will strive to make the girl a Sahasi with Swachhata, Samruddhi and Swasthya. To be Surakshit with Shakti to reach her full potential as a woman.
Dr. Shanta Kumari with the theme Foxy for All Always and Dira Stop Violence Against Women will empower many girls. I firmly believe that only a safe girl, Surakshit Kanya, can grow into a healthy woman, Swasth Mahila.
Violence against women. I think it's a silent pandemic and I'm so happy to be a part of this campaign.
If any woman has a problem, where does she go to? Not to the police or court or the lawyers. She goes to her friendly OB-GYN, who is her first point of contact for help. So I have started Dhira, an initiative close to my heart, to sensitize our OB-GYNs, the police, the public, and to partner with men to say no to violence against women.
I completely support her vision and mission as President Foxy and also especially support her campaign, Dira Stop Violence Against Women.
A healthy environment is the core of a woman's health. A healthy woman makes a family happy and a strong nation. I, as the President of Foxy, declare my commitment towards women's health and safety.
Yeah. Now I would like to formally invite Dr. Neeraj Jadhav, Chairperson of Foxy Sexual Medicine Committee, and Dr. Apurva, who is a media in charge, public relation in charge of Foxy Sexual Medicine Committee. They both will be moderating the session wonderfully as always, and they will introduce us to the faculty and chief guest for the today's session. So, Dr. Neeraj, over to you, sir.
Okay. Thank you. So good afternoon, everyone who have joined this wonderful session. of the on female orgasmic disorder. We successfully completed masterclass series where we covered all theoretical aspects of various sexual dysfunction. Now we have started this series, Confusion to Concessor, where we are going to discuss pure clinical scenario to learn about the practical aspect of managing sexual dysfunction. First session we completed was on female sexual interest and arousal disorder, and here comes the second session, which will be we will cover on female orgasmic disorder. Female orgasmic disorder, the second most frequently reported women's sexual problem. The Diagnostic and Statistic Manual of the Mental Disorder, 5th edition, classified FOD as a belonging to a group of sexual dysfunction disorder that are typically characterized by clinically significant inability to respond sexually or to experience sexual pleasure. The traditional view promoted by the Master and Johnson is that male and female sexual response is characterized by gradual sequential progression of event starting with the sexual interest and culminating in orgasm. However, this linear model has proved to be only marginally useful for assessing and treating women's sexual difficulties. According to current view, incorporate the idea that female sexual response of mind and body may follow more than one set of patterns. Problems reaching orgasm are fairly common among women. About 3 out of 4 women said that they can't orgasm through vaginal penetration alone. But there is a difference between an occasional issue and more persistent problem, that is FOD or female orgasmic disorder. So let's discuss today about the few cases we selected related to female orgasmic disorder, how to evaluate them and how to manage such type of cases. Today we have one distinguished guest as a chief guest with us, Dr. Suvarna Khandekar Madam. She is currently Deputy Secretary General of the FOXI. She is Professor and HOD of Bombay Hospital. She is editor of 12 books and many awards and prizes to her name. So welcome Suvarna Madam. Please bless us with your words. Over to you, Suvarna Madam. Madam, are you there?
Ma'am is there. Ma'am has to unmute.
Yeah. Yes, Neeraj, I am there. Just give me 1 minute.
Yeah. Okay.
Right. So, good evening to everyone who has joined for this wonderful webinar. Actually, I want to congratulate, first of all, Dr. Neeraj, who has been taking keen interest in this several webinars. It is not easy to have so many webinars on this committee. We have observed as FOXI office bearers, this committee is there since many years, but so many activities I am seeing for first time, and I must congratulate, and it is very hard to get people to even support these seminars. So I have to first congratulate Dr. Neeraj for this wonderful, efforts which are successful. It's not that everybody does efforts, but your efforts have shown that you can do so many activities, and there is so much to learn in this field. And especially I, as a president of past Indian Menopause Society, we have seen last I think couple of years back, Indian Menopause Society, World Menopause Society had kept female sexual disorder as their main theme of World Menopause Day, and they celebrated this World Menopause Day with after instructing all the countries to have these webinars, or those days it was not webinars, they were all physical activities. So all these activities were conducted under this heading. And we had seen last that year so many activities which were conducted, and I think Neeraj, you have done a great job after taking over as a chairperson. And of course, even previous chairpersons have done great job. But female orgasm disorders, as you said, it is not so rare. In fact, it is one of the most common diseases. And as you said, many women even say that they have never experienced orgasm. So it is very, very important to discuss these issues and enlighten our practitioners who can help their patients to have, I think, at least the best life, best married life, and they have a very good cordial relationship with their partners. So I think with these few words, I wish all of you all the very best. I can see Dr. Apurva, who is also there, and the whole team who is working with you. And in the past also, you have done so many programs. So I think it doesn't, happen this way unless it's a teamwork. So I congratulate the whole team along with you. And I wish you all the very best for even your future endeavors. Thank you so much for inviting me here as the chief guest. Thank you.
Thank you very much, madam, for your kind words. And in fact, madam, sexual health is such a topic. First, we have to be comfortable with the subject. Otherwise, we can't talk with the patient. It is very important that we should feel comfortable about this subject. Then only we can think about managing such type of patient.
Women are not even comfortable of, talking even menstrual health. Forget
Yes.
sexual health, even menstrual health, women don't come out and talk. So I think we have to, start that program, which we had some time ago started with some of the past presidents of FOXY and IMS. Let's talk. Let's talk. So it undermines the meaning of all the kinds of things which are not talked openly. Let's talk about them openly. I think that is the message hidden in that heading. And I think if you go ahead like this, many women will be benefited. And I'm sure all these are going to be, I think you are having many more now on this series.
Yes, yes.
This is just the second one, which I have just
This is
heard.
second one. We are total 7 sessions on this series.
Excellent. And wish you all the best. Thank you so much for having me.
Thank you, madam, for sparing your valuable time. And Apurva, now please introduce our faculty and start the session.
Thank you so much. First of all, thank you so much, Suvarna ma'am, for your kind words and your wholehearted support for our cause of sexual medicine. Thank you. Your blessings are always with us. Thank you so much. And definitely, ma'am, what you have told, because as a member of adolescent health committee, I have done a work regarding the menstrual cycle and hygiene. People are actually very afraid of talking about this menstrual health itself. So how we we expect that they are talking about the sexual health. So it is very bold steps, and definitely thank you so much to Neeraj sir to bring out these topics and with us. Thank you so much for coming, ma'am. So to start this program, the scientific program, my dear friends, now this is the second season, because in the first season we have already started and we have a 6 series of this type of masterclass series, and this is actually the second episode which we are getting. So in the first series, what we have done, we are talking about regarding the various topics, and regarding it's not a two-way introduction, it is just theory type. So in this series, actually, we are sharing with you a live sessions, a live questions and live patients, which we are getting in our day-to-day life, so that after discussing, it will definitely benefit you how to treat this type of cases in your day-to-day OPDs and activities. Today, we have a very senior and, personally my favorite person, Vijay Sarthi sir, as our guest for today. Everybody knows nowadays, those who are attending our series, they must know him. He is so down to earth, so soft spoken, and so a true academician. Sir is very senior consultant in the sexual medicine. He's an accredited psychosexual therapist and educator and lecturer in the sexual health at the University of Sydney, Australia. Thank you so much, sir, for accepting our invitation and to give your precious time for this series. So, as I have already told, we have the tendency to forget the things. So why not we revise that what is actually the female orgasm disorder in a very quick and in a very, within a few slides, and then after we will take the questions. So Vijay sir, over to you to have a brief introduction what is female orgasm disorder, then we will take up the question. Over to you, Vijay sir.
Oh, thank you, Apurva, and thank you, Dr. Jadhav and Dr. Khadika. So let's get cracking in. So let me share my slide. Are you able to see my slide?
Yes.
Apurva? Yep.
Yes.
All right. So once again, so I think the same day, 23rd of April, I was looking through my records. So 23rd of April this year, we did a session on female orgasmic disorder. Female orgasmic disorder. And after a few months now, we are having a case study discussion. So I thought, let me quickly run through. Apurva, I'm getting a bit of interference, but I don't know. Maybe if you can.
Sir, I will mute everyone.
Yeah, mute. Yep, beautiful. So, like, I think what Dr. Suvarna Khadika said, it's important. There's so much to learn and there is so much to know in the space of sexuality. And the way I see the connection between sexual health and reproductive health is that reproduction is part of sexuality. So those who are obstetrics and gynecologists are also a sexologist in many ways. And with Sydney University, I am in conversation with Dr. Jadhav, and Dr. Shantakumari ma'am has given her blessings to actually develop a custom-made, contextualized to the Indian setting, some form of master class in sexual medicine. So whatever we hear through webinars is great. It sort of sensitizes, creates awareness. But then if anybody is willing to formalize their knowledge, obviously that date is for Australia, but something like this is what we are going to develop. And Dr. Jadhav, I'll talk to you separately on that. But this is a university recognized course and will be run through the FOXI, and we'll make sure that it meets all the criteria for the CE points, but that's in the pipeline. Now, a quick recap of what is this female orgasmic disorder. So let's start with orgasm. Once we know what is orgasm, then we'll be able to better understand what is orgasmic disorder. And especially in women, there are a few things we need to be mindful of. So orgasm is highly subjective. There is no objective marker as in males. Now, when I say that, orgasm is closely associated with ejaculation, but even in men, orgasm and ejaculation are not the same, although it happens very closely. Now, orgasm is experienced in different ways, varies between individuals, and even in the same individual, it can vary significantly. So we need to be very mindful of that variation. And sometimes it's very hard to even take history, or for a client to give history, clearly describing what is orgasm, what is that they want to feel, and what is that they are actually experiencing. It's not a very, it's a typical definition, because of the subjective variability. So it can be hard in how they describe. Now, orgasm in men and women, there are a lot of similarities as well as differences. But once again, today's focus is on female, so we'll keep it to women. And the major thing, I'm going to discuss a case later, that still a lot of women have a lot of misconceptions and unrealistic expectations when it comes to orgasm. Okay, and a typical one is trying to somehow think that vaginal orgasm is superior to clitoral orgasm, without taking into consideration that vaginal orgasm is actually triggered, and clitoris plays a significant role even in vaginal orgasm. So there is nothing called the vaginal orgasm is superior or the vaginal orgasm is totally separate and different to the clitoral orgasm. So that's something very, very important. Now, what is female orgasmic disorder? Now, that first bullet point is very important. It's not just not having an orgasm, it's orgasmic disorder. So it could be a marked delay in or there is a marked infrequency or absence of orgasm. And sometimes they might get a small pulsatile orgasm, which is not strong enough to make them feel satisfied. So that is also brought under female orgasmic disorder. But when you look at the prevalence data, it's because of the subjective thing. The numbers are quite varied, but typically looking at around 29 countries, data from different countries, it's sitting anywhere between 18 to 30% of reported female orgasmic disorder. But it's quite variation. There's a big range there depending on how they take a diagnosed FOD. So once again, the DSM, the American criteria, stipulates that it has to be there for 6 months and it must cause distress. But once again, do we really need to follow DSM while we are practicing in India? Probably not, but it's a good framework to think, but don't try to put somebody within the box in order to get a diagnosis. End of the day, it is what they are presenting, and let's try to help these women and a couple if they are in a partnered relationship. Now, I think I've already shared this in my last presentation, but if anybody who is keen to further their knowledge in treating female orgasmic disorder, I would strongly recommend to go have a read of this article. It is freely available. It's in the public domain. I have given the reference, and that article has got so many other references, but I think definitely I would say it's a good place to start. Okay. So anyway, in terms of coming to the case study discussion, what is relevant is assessment and treatment specific information. Remember, we need to look into a lot of different factors. It's not just one line question. Do you experience orgasm? Yes or no? That's not the history. We need to look at the psychosocial level. We need to look at emotional cognitive level, and then also the relationship level. So there are a lot of things that is surrounding the orgasmic experience. So a thorough history is definitely the way to deal with female orgasmic disorder. Now, once again, so we need to take a good history of medical history and medication. So any comorbidity that affects the neurological, especially type 2 diabetes or multiple sclerosis, so those are medical conditions. When it comes to medications, very much SSRI is often the culprit, and also any traumatic experience in the past, childhood experience, all of that has to be incorporated. Now, once again, partner is very important. So we need to, if it is an acquired issue, and often if you read the definition for FOD, there is one specific word that we need to be reminded of, and that word is there's a market delay or infrequency or intensity, quote unquote, despite adequate stimulation. So whatever the woman is complaining in terms of orgasm, whether it's delay or absence or lack of reduced intensity, it has to be experienced despite there was adequate stimulation. If there is no adequate stimulation in the first place, then the whole assessment and diagnosing FOD becomes even more complex. So just bear that in mind. It's going to be very helpful when we are doing the case study discussion. Now, once again, what are the management options? Non-pharmacological plays a significant role because pharmacological, there is no strong evidence to say that these medications are going to work. Okay, but in the desperate to help them do something, we might try it, but I would take it with a pinch of salt that we don't have a strong evidence recommending any form of medication. But definitely non-pharmacological, especially psychosexual education, plays a significant role in managing FOD, both for the women and for the partner. It's very important. Now, This is how the case studies are going to present, but I'm just sort of giving a primer there. So there are a couple of different ways an orgasmic difficulty could present. Okay, so with partner, but not intercourse. Okay, so they might be able to experience it by themselves, but not with a partner. Okay, or somebody who has never achieved orgasm by any form. So that's something we need to be very careful when we are trying to classify the FOD. But classification is great, but in terms of management, it makes no big difference. Okay, so remember, that's why I put this in bold. This is the caveat here. It's very, very, very important that the woman has experienced enough psychic arousal, emotional, and physical. So that's very important. Without any of those three, it's going to be very hard to assess whether it's really an issue with orgasm or is there an issue with arousal. And remember, orgasm can sometimes be seen as a continuum of arousal. Okay, when there is an issue with arousal, then no way we can get to orgasm. So those are some of the recap. And I'm giving you a framework for taking sexual history. Now, when we take history, we are only taking history for two reasons. One, we are trying to assess in the back of our mind what could be causing the problem. On the other side, we are eliciting history to better understand the symptoms. Remember, it's very subjective, so therefore history plays a significant role. So when we talk about symptoms, not able to experience orgasm, we are drilling down into quantity and quality. What is the intensity? Was there a change in the intensity? So that's sort of the symptom, but history in terms of causes, whether it is an individual factors or is it a couple factor. Okay, so whether there is a difficulty in processing the orgasmic experience or whether the partner is not being able to adequately stimulate or whether there is a relationship problem. Remember, you cannot expect good sex in a bad relationship. That's the mantra there. Case formulation, I have shown you in the past. This is not in any way for a gynecologist to use. This is for somebody who is specializing in the field. But if you're very academically inclined, you're one of those, I want to do things right, you can always look into this formulation. One good thing is if you can chart it out, okay, where are the problems sitting in this grid, then you can clearly say, okay, so this person has got nothing biomedical, it all appears to be psychosocial. Then you have to say, okay, as a gynec, I have done my bit, I have ruled out certain causes, and this is not my area of specialization. Bang, you can refer to your counselor or psychosexual therapist who are dealing with this. On the other hand, if you're able to find some of the reasons, if you see all the biomedical boxes are filled, then probably you can say, okay, this is something I can deal with. So this formulation gives a clear picture whether you are going to deal or whether somebody else is going to deal. So it gives you some clarity on that. Now, these are the 4 questions that we are going to use for the case study today. Okay. So remember, history. Once we take history, we are going to case formulate. Once we formulate the case, we are going to go with the diagnosis. Once we have a diagnosis, we are then moving to the management. So simple 4 questions. Let's get on to the case study. So probably I'll stop here.
Yes, sir. Yes.
Yeah, Purba. I'll stop here and take.
Okay. Sir, thank you so much for briefly talking about this female organism disorder. It is just a revision for us, and you are summarized it so well. So, because many times what happened, what we have actually read is different what we are actually getting in the practice, and that's here is the concept of case-based study. So this is the idea of our own chairperson Neeraj Yadav sir. Why not to put this case-based study in this series? So to start this, just invite our chairperson Neeraj Yadav sir to start with the first case. Vijay sir, can you just share the screen so that I can share my
the case?
Yes, sir.
No,
I will share
stop
the
sharing.
case from my slides.
Oh, you want to show you? Oh, okay. You want me to stop sharing? All right. All right. Yep.
Okay. Thank you so much, Vijay sir.
Mhm.
Trying to. It is visible, sir.
No. Okay. Just slide are visible, not in full mode. Just skip the
Yes, sir.
initial slide.
Yes, sir. Already I have.
Yeah, it is
Okay.
seen. Yeah, okay.
Neeraj sir, to you.
Yeah. So let's start with the case discussion. So here comes the first case, Mr. Apurva and Lalit. They are married since 2013, living in Australia since 2015. 4-year-old baby they have. Both work full time, IT professional, and live as a nuclear family. Privacy is a no concern. So consult one on 10th of the 2021, Lalita, wife not able to feel my penis inside her. This is the word by the Lalit. And there is a quick ejaculation time by me many times. In consultation two, Lalita and Apurva achieved orgasm only twice. Lalita not being intimate and not spontaneous. That was the complaint by her husband. And couple not planning for a child in near future, and there is a no use of condom. So how to proceed in such type of cases, Dr. Vijay? How will you evaluate history examination and how will you manage this patient?
Okay. So you're using the slide. Okay. It's your slide, right?
Yeah.
Okay. I don't have control. Okay. So the first thing is, so this couple came to me, but first the male partner contacted me, and then I told him that it's important to consult as a couple, and then they had a couple consultation. So the presenting issue, as you read there, when the male partner said that he's not happy because his wife is not happy. And why she's not happy? Because she's not able to feel the penis inside. Now, it's important when we, I think I'm getting some interference, Apurva. Probably, do you want to mute? I'm getting quite a lot of interference. So the first thing is, it's important to take a good relationship history. And when we take history, straight away, if you go to orgasm and what happens in the penis and vagina, it can be too much for a patient. So I would normally start with some very gentle questions about their relationship and then move on to the sexual history. That's a take-home message. Because if you straight away ask, and when you're asking history, try not to ask questions that has an answer of yes or no, because by default, they might say no. So closed-ended questions are not preferred. Rather, convert those questions into an open-ended question. Say, for example, does your wife experience orgasm? It could be yes or no. Rather, you can say, how would you describe your wife's experience of orgasm? It gives a bit more room for them to describe it. Okay. Now, when the wife says that she is not able to feel the penis inside her vagina, what is that could be happening? Whether he's actually putting it in the vagina, that's something we need to be very mindful of. Whether there could be the penis size could be a problem, because the couple, they were engaging in quite a long foreplay. So that means there's a lot of lubrication. Therefore, the penis is not being felt as you would normally expect to feel. Also, postpartum, what happened to her pelvic floor? If the pelvic floor is not toned, whether that could be causing an issue. So we need to, sometimes we have to become like an investigative person. So we are trying to understand what could be causing. But when the male partner came, all of the issues he was telling was about his wife. But I didn't jump into a conclusion and started telling him what are the problems. I told him, whatever I heard from you is great, but can I also hear from your partner directly? The reason I'm telling this is, if you're Apurva, I think it's a lot of interference coming once again.
Sir,
Yep, that's good. So we lost sharing now. That's okay.
actually, sir, with sharing, I can't operate.
Oh, right. Okay.
That's the issue.
So the most important thing is to make sure, bring the partner and assess as a couple, because this is an issue that involves two persons. So it's important to take history from two persons and bring the history from two persons to make a formulation. So those are some things I would be doing, Dr. Jadhav. You need to unmute, Dr. Jadhav.
Yes, you just said about not a leading question, which can be either yes or no. We should ask question. We can have some detail by the patient. So, which type of question basically? You can just give us example of questions which we can ask to such type of patient.
That's right. So if you go back to the case study, do you mind going to the case study? So for this person, so they were trying in missionary position. Now, first thing is, what makes her feel that orgasm, the vaginal orgasm, she was so particular that the orgasm should be from the vaginal intercourse. So when we are taking history, we should be looking for what sort of shoots they are having. So in this particular couple, she was so adamant that orgasm should happen by vaginal intercourse. Okay. So when I'm consulting the female partner, so I asked her, so what is your concern? Doctor, I'm not able to feel orgasm. I'm not able to achieve orgasm from vaginal intercourse. Okay. Does it mean, okay, I hear that, but can you tell me about your orgasmic experience by other forms? So she says, yeah, whenever he stimulates my clitoris, I'm able to experience orgasm, but not through vaginal intercourse. Now that raises the question, okay, what is that you're particular about having a vaginal orgasm? All right. In her mind, vaginal orgasm is the orgasm. And in her view, from reading novels and watching porn, orgasm means a woman should scream and the body should become like a bow. And she has a set view that orgasm means it should be in a particular way. So when we are asking history from a patient, we need to tell them, okay, describe what is your expectation of an orgasm? What is your understanding of orgasm? And when we are eliciting history, simultaneously we are providing psychosexual education. And sometimes we will be strike that their understanding of orgasm is not realistic. They are having unrealistic expectation. So in this person, she wanted vaginal orgasm. And in that, the vaginal orgasm should happen only from missionary position. So I then asked, okay, what about other positions? Have you ever tried women on top position? Because that has got a lot more chances of triggering the clitoral hood. She said no. So my question is, okay, I understand no, but can you describe why no? Why not? She said, sex means a woman should be the receiver. The man should be on the top. That is sex. If I'm on the top, that is not real sex. So this gives an opportunity to clarify some of the misconceptions and address the shoulds that's in her mind.
So basically, you mean that this patient was not suffering from FOD, but only she needs education. We can't label her as a FOD case, right?
Well, that's right, because she is able to experience orgasm, but not from vaginal intercourse in the way the couple are doing it at the moment. Okay. So they are doing it in a missionary position. And moreover, Neeraj, you need to, if you read the case history, he was wearing a condom. And every time he was wearing a condom, he is also using lube in the beginning. And the couple were actually able to enjoy quite a lot of the sensual part of it. Okay. So in their mind, and she has plenty of secretion. So all of that is leading to the fact that she's not able to feel the penis inside the vagina. Okay. Now, while doing that, I've also made sure that the penis size, the length and girth are reasonably good. And he's definitely penetrating. So we need to make sure all of that, because women can be in a less powerful situation and men can sometimes take advantage of that, because in a missionary position, a woman is not able to visualize what's happening down. So if he simply bluffs and say, yeah, I'm putting it in, you're not able to feel it, unnecessarily the woman is being pathologized and medicalized here. Okay, so how do we ascertain that? So that's why we encourage positions where a woman can actually visualize the penis going inside. And that's where we have to say, no, it doesn't matter who's on top, who's on bottom. End of the day, you both are a couple, you both are a partner, and there is just the position of sex doesn't determine the power in a relationship. So she needs to be, and also she was expecting mutual orgasm, because in certain cultures, the expectation is the baby that is formed when both the man and the woman achieving mutual orgasm is expected to be very healthy and brilliant. What evidence do we have for that? Actually, what evidence we have, the orgasmic significance in fertility. Okay, but people get misinformed and start having unrealistic expectations.
In this case, only history part was important. Is there any role of examination or?
No, there wasn't need for any examination.
Only history part was we can.
History is very, very important. And also, I always take a good relationship history. So seems like the relationship issues were not a big issue now. But what's been happening is, because for the man, he knows that if he proceeds with sex and leads up to intercourse, he is not able to satisfy his wife. So he knows that. Because he already knows that he's not going to make her happy, he's not even starting anything. Because why start something which leads to something that it's not going to be successful or make happy ending for both of us? So rather, let's not start. So that is creating avoidance. That avoidance is creating a gap in the relationship. And for her, one side, she's complaining that she's not able to feel orgasm through vaginal intercourse, but she still likes that foreplay and the sensual bit. But for him, because it's not ending up the way she wanted, he's not starting. So you can see how the gap is widening between the two. And what's happening in sex gets translated to other dimensions of the relationship. I'm not happy in sex, so they start fight, they stop talking, and then communication, everything, there's a flow-on effect.
You said about the relationship issue. So what type of question basically you will ask to find out the relationship issues?
Okay, so I often, relationship, it's wonderful if somebody else pay for the client and we have 5 hours of time, we can be asking every bits and pieces. So the art of history taking is we need to be a bit open, but at the same time quite targeted so that we can move on. Otherwise, we'll be having 5 pages of history, not knowing what to do with it. So when I ask them history, I tell them, okay, on a scale of 1 to 10, how much do you think you would rate the current relationship that you have with your partner, excluding sex from it? Put away sex and just tell me, how would you rate your relationship on a scale of 1 to 10? 1 means very bad. It's almost critical. We are going to separate. 10 means we are made for each other. Usually they give 7, 8, 6, depending on the case. So when they give a number, Neeraj, the next question I ask them is, okay, tell me why you have given 7 and why not 9? Or look, when it comes, at times we have argument, or she has her way of doing things. He doesn't. And the next question is, I ask, if it is only male, I ask, okay, if I have to ask the same question to your wife, what number you think she would have given to you? Or she would have given the same number. So this way you have something objective, but at the same time, you're collecting some very specific information. And if they give 9, okay, tell me what is that you like about your partner? Or she's very supportive, she's very understanding, or she has a medical background, she understands. I keep that information in reserve and lift it and bring it when we are doing the management. Okay, the partner is supportive. So therefore, be open to try some new things. Okay. So how supportive the partner makes a big difference in trying out different modalities. But if the partner is not supportive, every time he fails in something, if the partner starts an argument, it's extremely hard to work with those couples.
So basically, it is a couple therapy. You have to counsel. In this case, you have counsel both of separately and jointly, or how?
Correct. So he came first. Whoever comes first will be the index. And then I recommend a couple. And then when they come as a couple, I always give time for a woman to voice out her concerns. Because we are men as a professionals, but we need to be supportive of women having their voice. Like Dr. Shanta Kumari ma'am said, and all others said, it's not to be proud or anything. This is a requirement. This is a basic thing. I follow that a woman gets her voice without a husband in the room. So that is important. And then we bring 2 parts together and then work from there. Sometimes it is important that I don't work with both of them, because if they both are in a different directions, I send that female patient to my female colleague who can deal with the female patient. I deal with the male. If the couple doesn't want to work together, we have to separate it. We cannot have both. Ethically, that is not correct.
Yeah, therefore I want to ask if both are not under your management, then it's very difficult to manage case.
Yeah, understand. But we can't have 2 clients who have issues between them and both of them are treated by me. Then I will be hearing something about the other person. How am I going to use that information? So it becomes very complex. It is better the one person gets treated by another person.
And what about couple counseling?
Well, if they come as a couple, if they want to work as a couple, no issues. But if the couple have got a problem between the two, it's important to give that space. But this is all we have the professionals here, whereas in India, this is where we need to be, very mindful what is available. If there is only one counselor available in the whole city, then what are we going to do? We have to take it with a pinch of salt and move on and help our patients. I'm saying this, Neeraj, because I have the opportunity to refer to someone, but that's not possible everywhere.
Sir, here that is the main problem, because what you have correctly pointed out, we don't have counselor. Actually, we as a gynecologist have to, have the duty of as a counselor, as a gynecologist, as a sexologist. And we have a lot of patients waiting. So the main problem is that we are not given enough time for the history taking. You have and you have what you have in this particular case. The history is very important. Secondly, the treatment part is, again, the counseling is the main treatment. So in that case, there is a no investigations, and actually the people have in their mind that probably if it is, we must have some investigation, or want some medicine so that they have those problems to be solved. They want it very quickly. So this is the main problem, and we have to give the time, because the counseling is the main issue in this case.
Absolutely, Apurva. But see, this is where I feel Foxy should take some steps to move on this whole field of sexual medicine. Okay. See, I can't talk to the medical council. Okay. Whereas Foxy as a body should lobby with the medical council, or whatever they call now. I think it's National Council or whatever it is, to actually recognize sexual medicine as a specialty. Without that recognition, it's going to be uphill battle. Okay, so we need medical doctors, and then we need psychologists and counselors who are specializing in this, and then the two professionals can start working together. Let's be honest, we can have a 1 hour session on FOD. Put your hand on your conscience and say, Apurva, when a patient comes, how much time you can give? Max to max 10 minutes. Okay, but the point is, you don't have to be a sexologist to help a patient. In 10 minutes, if you spend 3 minutes to genuinely listen to a female concerns, look, I may not be able to help you fully, but I'm willing to listen to you. And that is highly therapeutic, because they know there is somebody they can talk to. And then you can say, okay, look, I heard you. Probably you're having, this is something we can work on. This is something you need to be mindful that clitoral orgasm is as good as vaginal orgasm. And you don't need to have orgasm in order to fall pregnant. You can do this in 2 minutes, Apurva. Doesn't take much time. Okay. So put it that way. If you have 10 minutes, make the most out of the 10 minutes.
Basically, problem is that we have to find the root cause of the problem.
That's right.
Then we can help them.
That's right. That's right. That's right. But the most important thing is give 2 minutes to listen to the patient thoroughly. Okay. Just if you ask them to talk and if you start writing a document, then they will shut down. Okay. Put everything aside. Okay. Look. Tell me, you want to say something. What is that bothering you? I'm happy to listen to you. Probably we may not be able to address today, but how about you make an appointment or another time? Or we have a counselor in a hospital. Why don't you go have a chat with them? Or I have a junior doctor who is going to take some history. Would you be happy to share your concerns with him or her? And then we will review that history later. So that way, Apurva, you as a gynecologist, as a specialist, you don't have to spend 1 hour. You can have a junior medical doctor to take history, and you have the case history summary. And with patients, I'm sure in 10 minutes, you can do some decent work. What do you think?
Right. And Vijay sir, suppose in such case, it is in India, and husband is not willing to come, then can we help such type of patient or not?
Yeah, of course, yes. Because we cannot say only if you come as a couple, I'm going to help you. Who are we to judge that? Okay. It's encouraged. If you bring your partner, we can help as a couple. But look, if your partner is not willing to come, I'm still going to try and help you with whatever we could. Okay. And for sometimes, Neeraj, the women might not even wanting to have sex with their partner, and they want to know, how can I stimulate myself? There is so much media out there. There is so much knowledge out there. And vibrators, I don't know how common it is coming in India. Is it sort of you can get nowadays the dildos and vibrators?
But online we can get, but not that much.
Not a lot. But one of the key strategies in female orgasmic disorder management is directed masturbation. Okay. If you ask a lot of women, so we were talking about Let's Talk and menstrual health, Apurva and Dr. Suvarna was telling, how many of our girls and women have actually visualized their genitalia? Okay. So a nice tip for you, Apurva, in your hospital or through Foxy in your local chapter. Here in Family Planning New South Wales, we were giving a mirror. It's like a V-shaped, it closes. You open up, one side becomes a handle, other side becomes a thin mirror. So women were able to put it down and actually visualize their vulva and their vagina and the external genitalia. A lot of women haven't even seen it. So making them look at it, then they can see what is what. Okay. Now, a lot of women, Neeraj, going back to the psychosexual education in terms of orgasmic disorder, women are not aware of what is clitoris to start with. Yeah. And women are not aware that what they see on the top is only a tiny portion of clitoris. That's clitoral hood, but clitoris is on either side surrounding the vagina. Then you draw that picture and explain to a woman that, look, you are always thinking about clitoral orgasm and vaginal orgasm is so good and better than clitoral orgasm. Look at it. What is actually causing vaginal orgasm is the body of clitoris. Ah, okay. That's not too bad. There you go. That takes 2 minutes to explain and 1 minute to draw and show them.
And Dr. Vijay, problem is that sometimes many of women prefer sex during in dark, and they are not comfortable with their body. They don't like light on. So issue is that also.
What is that, Dr. Neeraj? It's a body image. I missed you a little bit. Sorry.
Yes.
So it's a body image. Correct.
Yeah. So what is it? What is that they're not comfortable with?
Because they prefer doing sex in dark, not with light on or anything visual. So
Okay.
problem may be that they are not comfortable with their own body, and then how convince them about the.
Okay.
We are telling that they should visualize. We can ask them to visualize their outer part, but in such type of cases,
That's right, because not everybody is comfortable with nudity. Okay,
yes.
A lot of people don't like to see their naked body. Sometimes they are not happy for their partner to look at it. Okay, yes. But that is something we need to make them understand that their mind and the body has to work in one unit. Okay, so I often refer, if women who have issues looking down and thinking it's a dirty organ, where it comes from, as parents, what we tell our girls, don't touch there, it's dirty down there. But we are making dirty to the urine that comes or the discharge that comes. But often the reference is made, it's a dirty organ. Okay. It's not the organ that is dirty. It is something that comes through that organ, smells, discharge. So you make sure it's hygienic, but also you don't touch it in public. But the organ is a beautiful organ like any other part of the body. So that comes from the developmental stage. The message we are giving as part of sex education has to be very positive. Okay, body image issues are very complex, Neeraj. It's not like they come, they have one talk with you, they are going to go away with very positive image. Okay, because doesn't matter how much ever we say, the mind focuses on what is not good. Okay, so it's very hard to convince, but you can reassure that how the body image, what impact it has on sexual function. Okay, it's not just that who look athletic or somebody who looks very fit and slim are the best performing sexual beings. That's not true. Yeah.
That's the main problem actually, because in India, or I think in this part of world, there is a hype. Like, why in India the fairness creams are so much at demand? Because everybody is thinking that being a being a white skin is more beautiful, being to have a fashionable dresses, the dresses and outfits of the western day, they will be more sexy, will be more things. These things are actually, it is deep rooted in the mind, even in the
Absolutely,
most
Apurva.
educated people.
True,
So this is very difficult. What you have stated is very correctly. In one sitting and just merely in 10 minutes with them, you can't change that. It is
You
a
can't
change
change that.
it is a constant change, and the change should be from the root level.
Root level and from multiple sources. What they hear from you, Apurva, that should be reflected in the media. Okay,
Yeah.
media, what they show in media is a perfect body all the time. Why it has to be a perfect body? Where that notion comes from? Okay, so yeah, it's a big social issue. And also understand, it's not just how they look. Some people who have very hairy body, that is not seen very sexy anymore. Okay, so that is a problem. And fairness, that's another issue. And then body odor. So there are a lot of issues that comes in the way. Okay, so it's about acceptance. It's about accepting the way we are. Okay, and that's a developmental issue that takes a long time to revert it. Mhm.
Very true, sir. So Neeraj sir, should we move to the next question?
Yes.
Yes. Okay.
Yes, Apurva.
Just I have to share it. So is it visible?
Yes,
Yep.
visible.
Yeah. Okay. So second case to you, sir, Vijay sir. Mrs. Geeta, 27-year-old, and Ajay, he is 30-year-old. Geeta is married 1 year ago to Ajay. He's 30-year male, and they are seeing you as a couple. She describe herself as a happy, sensual person, and say that Ajay is quite opposite, doesn't like to be sensual, intimate, or playful. They are yet to have penetrative sex. It's been 1 year and there's a no penetrative sex. Geeta has read a lot about orgasm in the magazine, watch porn, but have never experienced the typical orgasm to her. So the question is definitely, what history would you like to initiate in these cases? What is the sexual history or relationship history? What are the key issue in this case? What is your diagnosis and how you proceed with this individual couple?
That's right. So the key history to elicit is, what is that stopping them from having penetrative sex? Okay. Now, once again, sex is not equal to intercourse. That comes as part of the management and sexual education. If you ask them, how often have you had sex? They always think about intercourse. Okay. But if you give them a different definition of sex, that sex involves touching, kissing, hugging, caressing, and everything, including intercourse, you get a very different answer. Okay, so that's very important. Once again, to you both and the viewers of today's session, I encourage you not to use the word foreplay. Okay, because if you say foreplay, that somehow gives the message that there is a play afterwards. And that play is intercourse. And that is the play. Foreplay is nothing. Okay. Whereas when you're peeling onion, Apurva, you're not peeling the skin to find onion, isn't it? Whatever you're peeling is the onion. So likewise in sex, the moment you start touching, kissing, that is the play. Okay, and sometimes that is the play, and the play can finish without intercourse. But sometimes intercourse is part of the play, and it can or it may not lead up to intercourse, but let's enjoy everything that starts with. Okay. So that's number one. The other thing is, in this particular case, one very specific question that I ask to my patients is, what does sex mean to you? And I tell them, look, this is one of the easiest question to ask, but it's one of the most difficult question to answer. Okay. What does sex mean to you, Apurba, 5 years ago is not the same today. And it may not be the same 5 years down the track. So it changes over a period of time. So when I ask the question, what does sex mean to you at this time in your life? In that couple, Ajay said sex means having a baby. For her, sex means being happy. They are married only 1 year ago. They are not planning to have a baby. Therefore, in Ajay's mind, why even think about sex? We are not having a baby, so why have sex? Whereas for her, it is about being happy. Now, she hasn't experienced orgasm. Why do you think she hasn't experienced?
Maybe masturbation.
Correct. A lot of women, they don't know that women can masturbate. It's not the same way man masturbate. There's not going to be ejaculation, but that doesn't mean women cannot masturbate. Even men who masturbate, you ask them, do you know that women can masturbate? Oh, really? I don't know that. And sometimes when men are told that women can masturbate, they actually feel insecure. Oh, what if my wife masturbates, so she doesn't need me anymore? So we need to be very mindful of giving an appropriate level of psychosexual education. Now, when we suggest masturbation to women, or for that matter to men, we shouldn't sound very prescriptive. You have to do this. You never say anything like that in counseling or therapy. We only say, look, you're in the driver's seat. It's end of the day, it's your preference. My role here is to give you the guidance. End of the day, what you do, what you don't do, it's entirely up to you. Because it shouldn't feel that we are forcing her to masturbate. But as a health professionals, we can say there are no health harms associated. It is quite a common practice that a lot of women do, and there is no harm, and it is totally fine. So we can give them that reassurance, we can give them that permission, but we cannot tell them that you must go do masturbation. That can go terribly wrong. Yeah.
Just Dr. Vijay sir, tell us about the guided masturbation. What is it and how we can counsel patients?
That's right. So we call that as mindful masturbation. Okay. So mindful masturbation is about, so for men or women, when they know exactly where to touch to get aroused, they go exactly do that. And then they rush through it and they finish it. Sometimes men do that and they're still not happy about it because they didn't actually enjoy anything. So what we tell them is, don't be in a rush, the first and foremost. Well, if you want to do masturbation in a very calm and relaxed way, make sure you finish off your tasks for the day. If you have plenty of homework to do, if you have something very important to do, if you're going to masturbate, your mind is partly involved in masturbation, but the other half is thinking of the work that is pending. So try finish it off that. Now, men who or whoever, they masturbate quite a lot and feel bad about it, I tell them, look, do masturbation as a reward. Don't do it as a routine. You finish off certain work for the day and reward yourself. No problem with that. You can even do it daily. There's no harm in it. So with guided masturbation, directed masturbation, you tell them, don't go directly touch the most sensitive part. Start touching your whole body. Start around and then slowly move towards the more sensitive part. And also, excuse me, and also what they are using to stimulate. Nobody on earth going to look at the sky or ceiling and masturbate. Yeah, they need some form of stimulation, either a mobile or porn or the imagination. And sometimes partner do for mutual masturbation. I do it for you, you do it for me. That's totally fine as well. But trying and developing a nicer way of doing it is very important, provided they are willing to know how to do it.
Sir, in this particular question, yeah, definitely the female has that problem. But one is specific that they don't have still penetrative sex.
Okay,
So
in this case, you mean the Geeta and Ajay case?
Yeah, Geeta and Ajay
So,
case.
okay, let me hold on there. What do you think the problem with the women there? I can't see any problem there. I'm just curious to know.
Sir, maybe, yeah, in this particular case, because Geeta, what she have told, that she is watching porn, she is reading the books. So maybe she has all those fantasies. And maybe that partner should be like that, the sex and the foreplay can be go around hours together. Probably this is one of the main features, because it is very general and very that whenever we want to get some information or get satisfaction, we are seeing and the porn available in the internet, or we are seeing some magazine. So she is might have the unrealistic things in her mind.
True.
Probably
very good thinking. Very good thinking, Apurva. But in this case, now, whenever you see the word porn, our mind somehow tells, or whatever that's happening, it's because of porn. Okay. But that might not be the case. In a country that doesn't have sex education, formal sex education, where else do you think people will go looking for knowledge about sex? Pornography is the space to go. In this particular case, if you read the history, she is not demanding Ajay to give orgasm to her. She's only telling, I haven't experienced typical orgasm. So all she's trying to get across to you is it okay to masturbate? That is what she's slowly nudging you, because she might already know, okay, this guy, he's a nice guy. I like him. I love him. But he's not interested in partner sex, which we will work on. But up until then, I just like sex. Now, remember, the typical understanding is majority of men, they are always ready for sex and they don't care about care, love, affection. They just want plain sex. When we think of women, we always have a different view, that most women like to be cared for, like to have that affection, and then they will look for sex. But be mindful, in 2021, 23rd of October, we cannot be so sure about this difference. Okay, not all men are always just wanting plain sex. They also like to be loved and cared for. And not all women always wanting care. A lot of women just want plain sex. We need to acknowledge that. Now, the other thing when we talk about orgasm and female orgasm in specific, and I even had a client just before joining the meeting, he's not able to give me sexual pleasure. He's not wanting to have sex with me. So does it mean he doesn't love me anymore? Why? As a lay person, we think if a person loves me, he or she should be able to have sex with me. But the truth is, love and sex are not the same. You can love a person so very much and not have a tiny bit of sex. On the other hand, you can have plenty of sex with one person and not love them a bit. So we need to make it very clear that love and sex are not always the same. Sex is not an indicator of love. Okay. And a lot of men struggle. They love deeply, but when it comes to sexual functioning, they struggle and they fear that their partner is thinking they're not in love. And that's when the whole relationship problem happens. So in this case, she just wants to know how to masturbate and reach orgasm.
So that was I want to ask. In this case, only directed masturbation is only you advise, or you just counsel husband also, because husband problem was with husband was that he was not ready to think that sex is a for pleasure also. It's only for baby.
That's
So,
right. We
yeah,
talk about in every situation, Neeraj. We talk about it, and sometimes to do penetration with penis, a lot of things have to work. Okay, to lift a penis, there's a lot of neurovascular thing has to happen. But to lift a finger, it can happen without any effort. So we sometimes I teach my couples to use the largest organ in the body coupled with the most powerful sense in the body. So your skin and touch, I'm referring. Skin is the largest organ. Touch is the most powerful sense. When we bring this together, the whole body is a sex organ. Why you're focused on just genitalia? Try and explore the body. A woman who's not able to reach orgasm, even with clitoral stimulation, doesn't mean she cannot achieve orgasm at all. For some women, the great toe is very sensitive. For some women, the nape of the neck is very sensitive. For some women, the nipples are very sensitive. But that is the beauty, that is the art of sex, for the partner to explore the body and find where the triggers are.
One minute, Vijay sir, just you said about this, John, but it is for arousal or for orgasm? This all zone are important.
Well, arousal, it's about arousal, and then it reaches there. We can,
Okay, sir.
yeah. So if you are in a manual mode, you start with first gear and then you move on to the fourth gear.
Okay.
If you're in an autopilot, you can go directly to drive. So sex is like that. You need to start somewhere, and then you're pretty much triggering different parts of the body. And it's like a whirlpool. If you start somewhere, and then once it starts spinning, then doesn't matter where you touch or don't touch. The spin is already there. It's all about getting the trigger on. And remember, the mechanism, how it works is when a woman is already aroused, once they are aroused to a certain level, then their interest starts building up. If you wait for them to initiate sex, they won't. But when you initiate, arouse them, then their interest comes. So they become more responsive than being the initiator.
Yeah, basically it is circular model you are talking about.
Correct. Exactly.
And in this case, I was thinking, what was more important to solve the problem of the patient, like she need orgasm, or we have to teach them about the proper sexual method and how they can jointly do this, or we can
Both.
Yeah.
Both. Don't take one over the other.
Okay.
Let the couple work as a couple, but also empower the women to take responsibility for their own sexual pleasure. And it's important to recognize that it is their fundamental sexual right to feel and enjoy pleasure. Okay? It is declared as one of the sexual rights,
Right,
as per the WHO. But women should also be encouraged, educated, and empowered to experience for themselves, and rather not always wanting the partner to do it.
right.
Okay?
Should we move to the next question, sir?
Yes.
Yep.
Just sharing that, sir.
Is it useful, Apurva? The questions, answers are helpful?
Definitely, sir, definitely. And because this type of, we never think of and we never talked about that. Now, when it's come like in this particular second question, even I am using and I am dealing with the sexual medicine. But I am graded it as a not FOD, but I will take it as an unconsumable marriage. So definitely these type of questions are doing a lot of benefits to us and clears our doubts, sir.
Thank you.
So over to you, Neeraj sir, for the next question.
So here comes our third case. 24-year female. Lady is a single woman and has no current stable partner. She engaged in multiple casual sexual encounter on Planon and likes condom-less sex. In between sexual encounter, she also enjoys self-masturbation. Her presenting issue is that she has not been able to achieve orgasm in last 6 weeks, despite changes in the way she masturbates. She has not engaged in partner sex for last 6 weeks due to COVID-19 lockdown. She lost her job during the lockdown and she has a previous history of depression also. So how will you evaluate this case and manage
Okay.
this case?
So in this particular case, she has been experiencing orgasm, but in the last 6 weeks, she is not able to experience orgasm. Now, so we need to be very mindful of her. Just because we are discussing about orgasmic disorder, don't get all narrowed about orgasm. You should always see Meredith as a whole person. Okay. And one of the problem with the modern day medicine is the specialties are becoming too narrowistic. We all get focused on one issue and forget the whole person. So Meredith, yes, she's complaining. She's not able to achieve orgasm. But hang on a second. What else has happened in her life? She's been having a lot of casual encounters and she's not using condom. Okay. Yes, she was diagnosed with an STI, which can sort of having a diagnosis of STI can be very disturbing for some people. Okay. Not for some people, for a lot of people, especially when they have the first diagnosis of STI. So in her case, we need to be understanding of that. Number two, she already has a history of depression. Now, when it comes to female orgasmic disorder, two mental health issues that we need to be very, very, very mindful of: depression, and clinical anxiety. These two are very, very, very important to rule out. And also women with OCD, obsessive compulsive disorder, have a higher rate of experiencing orgasmic disorders. Okay, so these three, but forget about the OCD, might not be that common, but definitely depression and anxiety, clinical anxiety. I'm not just feeling anxious, it's about clinical diagnosis of anxiety are very important to rule out. And depression, Apurva, how does depression manifest in lot of Asian, South Asian ethnic population?
Sir, first of all, in this particular case, a lockdown definitely bring a
Correct.
lots and lots of depression.
Correct.
People lost their job, they are unable to gather, this type of, even we doctors, why we are doing the CME so much, so frequently in our society, because just
Correct.
get together, exchange our thoughts, and we will be happy.
True.
So
True.
these cause, when the lockdowns and everything, the people has a lots and lots of depression. So depression lead to definitely the sexual
Correct.
dysfunction.
Correct.
And definitely this is maybe the cause.
That's right, Apurva. Let's forget about lockdown and things. In general, in a ethnic population, how does depression gets presented? Nobody is going to come to you or to any medical doctor and say, Doc, I have depression. Nobody is going to do that, right? How does it normally manifest? Or what other condition? It's a musculoskeletal condition that when a patient presents with, that you always think of depression, unless otherwise proven. What is that condition?
Sir, patient
Because
is
with the loss of appetite and physically they don't.
Musculoskeletal is low back pain. Okay, unexplained low back pain almost always comes with depression. That's the psychosomatization of depression. So this has come, and often when women say, if you think the symptoms are vague, doesn't gel up, there is no history of trauma, no injury, nothing, but still chronic non-cancer low back pain, always think of depression. And when depression, almost always female orgasmic disorder, there's a lot of coexistence. So we need to be thinking from different point of view.
Because it's a very new point, because
Definitely, sir.
when such type of patient comes with the low backache complaint, we usually think there is should be deficiency of vitamin D and should be deficiency of calcium. Never think about the depression. So
always there's not just a little bit, there's heaps of evidence for that. When I'm saying heaps of evidence, it's well documented. If it is but low back pain, if it is chronic, if it is there for more than 6 months, if it is a chronic low back pain, we have to rule out any cancer. So once it becomes a chronic non-cancer low back pain, then we need to be investigating depression. Now, what depression does? Depression or any mental health issues exacerbate the physical complaints. Okay. So, and imagine a woman with low back pain and depression presenting with orgasmic problem, you can clearly connect the dots. Yeah. So the message from this case study is, when a woman presents with orgasmic disorder, just don't get truly focused on things, have a holistic approach.
Very true, sir.
Yep.
Sir, when we are talking about this female orgasm disorder, does pharmacotherapy has some role? Because in these different type of 3 cases, and the counseling, taking the history is the main important. You never mentioned even a single drug. So is there any role?
No. See, when I'm saying it, I'm telling what is the evidence. I don't want to simply say something, blabber and go. I need to be honest, right? So there is no convincing evidence to use medications. You can try, okay, you can try bits and pieces, but in terms of evidence, nah.
Is there nothing? Okay. Because, sir, what is, because our mindset is like that, we have certain problems, we want some medication, take it for 5 days, 7 days, and we will get cured and our life will be. So nobody wants to give a long term and don't want to chase their particular, their particular, the position, particular habits. They don't want to change that. This is the main problem. Even many times I am getting this type of cases, and सब कुछ medicines नहीं है क्या? You don't have any medications to correct it. So I think that is the bottom line message to all our viewers and all those who are practicing here. It is that counseling part is the main one, and pharmacotherapy.
That's right. See, there were some trials. Okay, in 2015, there was a trial with about 125 women where they compared. There is a plant-derived extract, Apurva. It's called Alegnus angustifolia. Okay, so that along with sildenafil, they tried it, for 35 days. Okay, but there was some statistical differences, but there was no clinically meaningful difference. Okay.
Okay, sir.
So therefore, the evidence is not convincing. The other thing is oxytocin. Okay. As a candidate for pharmacotherapy, but once again, there is no sort of very convincing effect. Okay. Now, partly the problem with medication is that, once again, this whole reporting of orgasm is very subjective. Okay. Hello?
Hello? Yes, sir, you are audible, sir.
Okay, so that's what I'm saying. So as of now, there is no convincing evidence to say this medication, if you give it for this dosage for this long, will show this benefit. No.
What happens, sir? We are in our term, we are giving some kind like coenzyme Q or something like that. So I feel yes, there is improvement. Probably this is the placebo effect. A patient are getting something. Yes, doctor साहब ने कुछ दिया है.
Yeah.
Probably this is the placebo effect, maybe. But what you have saying is very true, because in
True.
all those 3 cases, you have beautifully explained that is the only the counseling and successful part. What
right.
will be the treatment of choice?
That's right. So once again, the placebo effect, if it works, well and good. But if they start believing that only with medications I'll be able to achieve, then we are creating some form of dependence. Now, if the coenzyme Q is not creating any trouble over a period of time, then it's fine. But imagine if people start buying it online, desperate, if it goes out of control. Okay. But once again, sometimes to get over the line, we might want to use some medications to just boost confidence. But then what will sustain that improvement is all that we discussed before.
Very
Yep.
true, sir. Yes, sir. Sir, but one thing what I would like, because many times this female organism disorder is due to the problem in the male partner. So in that case, we definitely have to treat that.
Once again, if I remember, I said adequate stimulation is very important. Now, before labeling a woman with female orgasmic disorder, make sure whether the stimulation was adequate and appropriate. Okay. A man with a very small penis, he may not be able to stimulate enough. But sometimes a small penis is enough if he is able to stimulate the right spot. Okay. If he is able to stimulate the clitoral hood, then he'll be able to get the arousal, the stimulation. A man with a long penis doesn't necessarily guarantee that it's going to end up in orgasm. Okay. So remember, always tell women, men, whoever you're dealing, that brain is the main sexual organ. And then the genitalia. And what is the other sex organ that is very close to the external genitalia?
Skin.
That we need to take into consideration when it comes to sexual functioning. Do you know that structure?
Sir, skin is definitely.
Skin is outside. There is another structure. It's not an organ. It is a structure that is very close to the, sorry?
Pelvic floor.
Correct. Pelvic floor. Very, very, very important. You wait and see in the next 5 years, there's going to be a lot of research on pelvic floor. Okay. Because how tight it is, how relaxed it is, because there are so much of neurovascular passing through, it has impact on erectile functioning. It has impact on vaginal tightness. So there's a lot coming through it.
But Dr. Vijay, if there is a big pelvic floor, it will affect only vaginal orgasm, not clitoral orgasm.
That's true, but it's about the pain sensation. It's how much they are contracting. So I'm not pointing out one or the other. I'm just telling in general, the pelvic floor plays an important role. Whether it be penetration or whether it be in male, it could be erection or ejaculation. So we need to be mindful that it's not all about the genitalia. Yeah. Thank you, Dr. Jadhav. Yeah, sorry.
Apurva, is there anything, any question is there? Or?
No, sir. No, sir. There's no questions. I think Vijay sir has touched each and every aspect. And in the last, definitely the very important question where the pharmacotherapy has some role. And he straightforwardly said, no, it was wonderful.
Okay. No, it's a pleasure always to share my knowledge and respect of the time difference. So it's always a pleasure, Dr. Jadhav and Dr. Datta, so for having me. So thank you.
Thank you, Dr. Vijay sir. And Apurva, you can have a vote of thanks and then we can finish.
Yeah.
Apurva,
Yes, sir.
we can finish with the vote of thanks and then we will wind up.
So thank you so much, first of all, Vijay sir, to bring out this beautiful session with the live cases, which actually these cases are the true cases, which is solved by none other than but the faculty for the today, that Vijay sir, and he's nicely put all the statements and how to proceed with that and how to deal with that. The bottom line message is that please spend some time with your patient. Please ask them and please give at least 10-15 times to your patient and try to solve according to the cause. This is the main bottom line message. And pharmacotherapy till date, no, not a treatment for the female orgasm disorder. Thank you so much, Vijay sir, for giving us the time, for blessing us. And thank you so much for FOXy President Dr. Shanta ma'am, the Vice President in charge Vipin Pandit sir, our own Secretary General Dr. Madhuri Patel ma'am, and the chief guest for today, Suvarna Kalindkar ma'am, for giving the valuable time. And thank you so much for the person behind this whole program, our chairperson Dr. Neeraj Jadhav sir. Thank you so much, the supporting team, the LAI and the entire pharma, to give always giving us the platform and always do our things better. Thank you so much for everyone and our viewers for giving us their valuable time. Thank you so much.
Thank you. Thank you.